Hello, welcome to the IEC virtual meeting on biomarkers at the SID 2021. My name is DirkJan Hijnen. I'm a dermatologist working at the Erasmus Medical Center in Rotterdam, the Netherlands. I'll be discussing with you today how I think we can get from clinical phenotypes to biomarker-based endophenotypes in atopic dermatitis. These are my disclosures. So I think we all agree that atopic dermatitis is a heterogeneous disease, and there's many different levels of heterogeneity. There's intrinsic versus extrinsic atopic dermatitis, patients with or without filaggrin mutations. There's different developmental profiles or trajectories. So patients with food allergy, with asthma, with rhinitis, with a severe AD in childhood, and then it disappears. So there's many different trajectories. Kids with atopic dermatitis tend to be different from adults. There's many different racial differences, both from the outside as on T-cell level. There's been some really nice publication from Kenji and Emma. And then when you look in daily practice, there's the different clinical phenotypes. No two patients with atopic dermatitis are exactly the same. So these are some of my patients. Some are really rare, some more like lichenified. Some have frequent secondary infections. Some have severe involvement of the hands and others not. So it's not only phenotypically complex, it's also complex when you look at genetic factors. So there's genetic factors involved in immune regulation, factors involved in the skin barrier and microbiome, but also non-genetic factors playing a role in immunology and in the barrier. So until now, we have used the umbrella term atopic dermatitis for all of these different phenotypes that we've been trying to separate in order to, for example, to predict treatment response. But I think so far we haven't been successful in that aspect. Under these phenotypes, there's different disease entities with specific underlying mechanisms that we call endotypes. So these endotypes can be defined using techniques like genomics, transcriptomics, metabolomics, or proteomics. And they represent specific groups of patients with specific underlying mechanisms. How these endotypes correlate to phenotypes, we don't know. If there is a correlation between the endotypes and the phenotypes, we don't know. It may well be that in the future, we will take a blood sample or a biopsy and we will say, this is endotype A. And we won't be able to distinguish a patient with endotype A from like clinical characteristics from an endotype B, but this endotype A patient may respond best to a certain treatment. And that for a dermatologist is of course a big change, because we are used to describing patients really well. We know our patients and we look at our patients really well. So one of the aims of medicine, of future medicine, is to select the right drug for the right patient, precision medicine. Will that be possible for the classical systemic immunosuppressants? I don't think so. There's been a few attempts like this one, but so far not successful. These are broad immunosuppressants. I think that particularly for the biologics, for the targeted therapies and the JAK inhibitors, this may be an interesting opportunity. We know that both biologics and JAK inhibitors are not equally effective in all patients. When you look at a very strict endpoint, IGA 0 or 1, so clear or almost clear. So these are the super responders to treatments. That is true for a max of 40% of patients on dupilumab. I'm not saying that the other 60% does not respond, but the best responders, the excellent responders are about 40% for dupilumab. For the other biologics, these percentages, the studies are not the same, so these percentages are just an indication, but it's usually less than 50% of the patients that are excellent responders. So in the future, we do want to select the right patient for the right drug and not start with A and then B and then C and see what happens. This is basically what we do today. There's a new drug available. We give it to all of our patients. We see what happens. And if it doesn't work, we'll select the next patient. That's basically what we still also do in psoriasis. in the future, you want to select the right patient for the right drug before you start treatment. Well, how can we get there? This is the subway map of London, which is difficult to read, and so far I think we've all been starting at different stations. So back when I was in Utrecht, we started by looking into blood and dry blood spots, investigating serum biomarkers, dry blood spot biomarkers. Others have looked into, started at a different station and looked at tape strips. So particularly in children, that's a really interesting opportunity. It's less invasive, and many of our patients with atopic dermatitis are, of course, kids. So a different level, different approach. Patrick Brunner's group from Vienna recently published a paper on suction blisters. People have looked into physiological properties like Tuel or NMF. And Emma has particularly looked into skin biopsies in AD patients. So I think these are all excellent approaches, but I think there's a need to integrate these data in the end, and I'll come back to that. So one more slide on what we've done in the past is we looked into 200 patients, 200 moderate to severe AD patients. We looked at 150 serum biomarkers, so cytokines, chemokines, etc. And we tried to see if there were different groups of patients that were clustering. We did find 4 different clusters of patients, and two of these clusters encircle the 38% of the patients, the 200 patients, had high expression of Th2 family cytokines, and they were also different in some ways. The interesting thing is that 38% of our patients, daily practice patients, were in these 2 clusters with the Th2 high expression levels, and that corresponds to 38% of the patients that have a PGA clear or almost clear after dupilumab treatment. So after a Th2 targeting treatment, these patients become clear. This might be total coincidence, but it would be really interesting to see if these patients do indeed respond best to dupilumab treatment or to another Th2 targeting treatment, but we don't know yet. So that'll be the next step. So how can we get from endophenotypes to predicting treatment response? I think the easiest way, the best way probably would be to use samples from randomized controlled trials. These are large sample sizes. Patients are usually on monotherapy without concomitant medication, without medication for other indications, etc. So that would be, I think, the ideal world. But then we have to convince pharma that targeting the right patient with the right drug is really the future. And well, I think we're not prepared for that yet. Next best is to do it in daily practice, prospective clinical trials. There's an interesting study going on in Japan in which they were treating patients with dupilumab in a prospective trial, and there's some limitations for the patients as to there's no overlap from classical systemic immunosuppressants or prednisone to dupilumab. They cannot switch from one topical steroid to the other. So this is going to be an interesting study when the results come out. And then finally, of course, you do want to predict treatment response in daily practice, and you want to know if these concomitant medications are okay, are still if predicting still works in these patients. So in summary, disease heterogeneity in atopic dermatitis has been unraveled on many different levels, and I think it's key to integrate these multi-level data. That will lead to a better understanding of the differences that drive the different endotypes. Selecting the key drivers of these endotypes, maybe from different levels of data, so from different levels of analysis of stratum corneum with tape strips, biopsies, serum. Of course, it would be easiest if we can just use a single tape strip and distinguish the different endophenotypes, but it's probably not going to be that easy. But I think in the next couple of years, we're going to have to see if the integration of these data will result in predictive biomarkers. Thank you.